I'm an obstetrician and gynecologist from ChanRe, Rheumatology and Immunology Institute. Today, as you all know, we've been doing the series on polycystic ovarian syndrome. And today specifically, we will be talking about the diagnosis of PCOS, the treatment of PCOS, and the most important and the most awaited part would be the infertility associated with PCOS. What are the causes of the infertility? How are we going to diagnose it and how are we going to manage it? So first, let's start off with the diagnosis. When we talk about the diagnosis, there is no no guidelines as such, but what we universally follow is a Rotterdam criteria. In this, the most important things would be cycle irregularity. So that could be a long period or absence of periods, or we would call it amenorrhea, long-term amenorrhea, where the oocytes are not released, so the cycles do not happen regularly. Sometimes for a long duration of time, the cycles may not even come. And sometimes even medication will be required to initiate the bleeding. Second thing would be the diagnosis which we do based on the biochemical changes that could either be clinically represented or in the blood investigations. Like in my previous video, I had told you that one of the commonest cause and one clinical features why it happens is because of the increase in the male hormones. So what we do here would be definitely in the blood investigations, the hormonal panel, wherein we will be estimating definitely the female hormone in the form of FSH, LH and its ratio. Along with that, the male hormone also will be estimated in the form of serum testosterone. So blood investigations or chemical present or the clinical presentation of the increase in the male hormones in the form of acne, hirsutism, or increased coarse hair on the face, upper lip, on the side locks, hair loss. So the clinical presentation of the increase in the hormones. So that would be the second one. And the third one would be on the scan. On an ultrasound, when we do an ultrasound, as we all know, what we're going to be looking for is in the ovaries, how are the patterns of these follicles. As we already are well aware of polycystic, multiple small cysts in the ovaries. And predominantly what we see here is these follicles are arranged in the periphery or towards the outer lining of the ovary. So when there is more than, say around 10 ml size of the ovary, or when there is more than 20 follicles in the ovary, this will be one of the criteria. So to summarize, the first one would be the cycles irregularity. Second one would be the biochemical changes, which can either be estimated by blood or by clinical presentation, and the ultrasound. So these are this is the criteria that we usually follow whenever there is suspected PCOS and we have to manage it likewise. Initially, when we go to the gynecologist and you kind of mention that the cycles have been irregular and you tell your whole history in the form of giving them the changes that the skin has been having or the weight gain, all that we have spoken about in our first session. Doctor will do a thorough clinical examination. She will check for the abdomen. She will see if there's any cyst, any palpable mass in the abdomen. She will do a vaginal examination also if the girl is active sexually to look for any significant changes. Then would be the blood investigation, wherein we will be doing definitely the hormones like I already said. But along with that, we will also be doing her hemoglobin status, a thyroid hormone, sugar status. So we would even be doing HbA1c to look at her sugar status over the 3 months. For some of them, when required, we will also be doing the fasting insulin levels. So blood investigations will be one of the next few things that the doctor will prescribe, which will also help her in deciding how exactly we're going to be managing the patient. Next will be the ultrasound. Like I already explained, this is what we will be doing. Most of the time, a transabdominal ultrasound is enough. But if very much required, we may also do a vaginal scan. So along with this, like in the previous session, we had spoken about some complications. So always keeping in mind the complications, routinely when the patient comes to us, her sugars, her blood pressures, her cholesterol level also will be estimated. Along with that, Clinically, we have to make sure that we speak to the patient, find out if there's any early features of clinical depression or anxiety. And screening for a sleep apnea, which I again mentioned to you earlier, that also would become a vital requirement when we go for a routine check. So, to brief you, diagnosis would basically, most of the time, we will almost draw a conclusion of this could be the condition based on the history. After that, a thorough clinical examination, then a ultrasound showing the features of polycystic ovarian syndrome, and a blood investigation showing the increase in the male pattern hormones and an alteration in the female hormones. Now, let's talk about the treatment. When we talk about the treatment for PCOS, the first and foremost, the most important thing that we gynecologists will say will be lifestyle modification. Sounds too easy when we say lifestyle modification, but it is one of the key features and one of the most important thing for PCOS. I keep telling my patients, especially the young ones who come to me, and kind of really hurts to write a lot of medications for them. So a thorough counseling is very required, very important for them to explain how their involvement in managing PCOS is. So in that way, when I talk about lifestyle modification, it will be the change in the diet, quit the bad diet. I know it sounds really harsh when I say that, but following a clean, cleansed, good diet would be very, very useful in managing PCOS. Second thing will be physical activity. It need not just, can't force anyone. You can't say that you have to do only gymnastics or you have to only go hit the gym to cure PCOS or help reduction of PCOS. Do yoga or aerobics. um, what we would really say to women will be any form of physical activity. So yes, each of them have their own pros and cons. The cleanest and the easiest and the safest would be yoga. Yoga, definitely, multiple such studies have proven that yoga has a deep impact in reduction of the symptoms of PCOS, also helps in some amount of reduction of the cyst in the ovaries, change in the hormonal patterns, along with the diet, obviously, along with sometimes they will even require the medication that the doctor is going to be providing. So yes, to lose weight, we will tell them, we will give them the diet plan as well as counsel them regarding the physical activity that they need to start following. And once that is clearly explained to them and they have understood the importance of that, we will also be using medications. Um, when a girl doesn't have a cycle for quite some time, say around for continuously, if she's not having her cycles and she needs the aid of hormones to cause bleeding, then we will definitely provide her those hormones. To regularize her cycle, we will be providing a combination of hormone, that is a combination of progesterone and estrogen. Most of the time, what we provide will be birth control pills. So that when it has a combination of estrogen progesterone, it also decreases the androgen, that is the male pattern hormone in the female body. This, along with that, OCPs also has one thing of reducing the risk of endometrial cancer, and also this irregular bleeding and spotting, which they have, also is regularized. And the excessive hair growth and acne also is controlled when we give a combination of hormone just to regularize the hormones in the body. So the first one would be combined birth control pills or a combination of estrogen and progesterone. Progestin therapy, we say, is by giving progestin for around 10 to 14 days, every 1 to 2 months to regularize the period. When some of the patients, we cannot give them estrogen, say high risk patients, SLE patients, and them we would prefer giving progesterones. So that would be given, say, around 10 to 14 days for around 1 to 2 months to regularize the cycle. When I'm giving her and trying to regularize her cycles, the hormone, when I'm trying to regularize, I will definitely tell her to make an effort to put in the parameters, that is the lifestyle modification and dietary changes. Now, when I talk about the dietary changes, it's very clean. We kind of explain to them how important avoiding red meat is, or dairy products, or refined sugars are. Sugar per se can increase inflammation in the body. So obviously, we will counsel them about these food, which has to be definitely avoided, especially packed food, a lot of trans fat. What they can have as alternatives would be a lot of fruits and vegetables, colorful fruits. So when I speak to my patients, I tell them, make sure that you have a lot of colors in your meal. A salad which has a lot of greens, reds, yellow will definitely work out. It reduces the free radicals and increases the antioxidants in the body, and thereby reducing the inflammation. Like I'd already told you, chronic low-grade inflammation, one of the commonest cause of PCOS. So to cleanse that, we will require a lot of these vegetables and fruits, which can be consumed in the form of salads, soup, or many others. An Indian diet is known to be very PCOS friendly. Now, let's talk about what are the other medications that we use. Some of them, when PCOS, especially obese PCOS, they may also who have a little bit of abnormal sugar levels, they will require an additional amount of medication in the form of, say, oral hypoglycemic agents. Commonest of what we use is metformin. Along with them, some of them who have a lot of hirsutism or hair growth on the face, they will require other medications in the form of spironolactones and others. Now, when a girl comes to us, particularly with the intention of getting pregnant, or she has PCOS, her cycles have been really irregular, when she is planning for pregnancy, her medications would be a little different. So, what we do here is provide her with certain medications. What we use here is clomiphene citrate or letrozole. So these are medications that we use to trigger the ovary to produce the egg or the oocyte. So these are the medications which is required to increase or to release the eggs. Some of them may even require gonadotropins. Now, these are the medications. This I will talk to you in a little more detail when we talk about the infertility. So to summarize, commonly used oral contraceptives or a combination of progesterone, estrogen. Along with that, we will definitely use a lot of medication which can kind of, like myoinositol, which kind of reduces the inflammation in the body. Metformin, spironolactone, and these are the additional medication. Now, coming to infertility. We have had a lot of questions about infertility and PCOS. Yes, definitely one of the treatable causes for infertility is PCOS. Polycystic ovarian syndrome, wherein the cyst is going to be filled with small cysts, which is going to prevent the production of a healthy oocyte, which can develop into an embryo. So these can be in various stages. Sometimes it goes into a resistance phase where, in spite of giving a lot of hormonal supplementation, the oocyte may not get released. So it becomes very important for us to see what stage of PCOS is she in. So when a person comes with a history of irregular cycles and she has scans which shows that there is a scan which shows that there is a lot of changes of PCOS. Second thing would be that there may also be a blood investigation which is supportive of PCOS. So in these cases, what we do is we will start once we investigate them and find out what is the status, we will start ovulation induction. Initial few days, if it has only been 1.5 to 3 years, then definitely we will counsel them about the lifestyle modification, give them supplement medications, and tell them how exactly they can start monitoring their cycle, regularizing their cycle before we plan pregnancy. So ideally, yes, we have to start regularizing the cycle, lose a little bit of weight, which also helps them in their pregnancy because it reduces the chance of gestation diabetes and also complications associated with pregnancy. So definitely regularizing the cycle, important. Now, after a period of time, when this happens, what we do is we start giving them ovulation induction. Ovulation induction is a method by which we use medicines to increase the oocyte production from the ovaries. So by giving so, how do we ideally do this? We ideally do this after investigate them with their blood investigations on hormonal status. We will start the medications from day 2 and we give it for 5 days. After doing so, we will start monitoring how the follicles are increasing in their size. Some of them will require additional injections to enhance the growth of the oocyte or the follicle. Even the lining has to be evaluated. PCOS, some of them can be associated with very thin lining. Even that has to be addressed during the course of time. So once you meet the doctor, they will definitely give you a whole list of how you will take the medications for 5 days. Then you will start having your follicular monitoring from day 10 onwards. 10, 12, 14, and how it is going to develop and when it is rupturing. This is what becomes the basis. Next, after that, we will tell them to have time to recover. So we'll tell them 14 days is like this, and next day maybe it will rupture. After it ruptures, and we have features of it rupturing in the scan, we will tell them you can try naturally. If the semen analysis is normal, definitely we will ask them to try naturally. Now, over a period of time, when ovulation induction fails, it can be combined with IUI, wherein when the egg is rupturing, we time it, and a process of in utero insemination can be done, wherein the semen is taken outside, processed, and injected into the uterine cavity. But multiple failures will then lead us to investigating how exactly is the ovary. Would it need surgical intervention? So when we talk about surgical intervention in PCOS, what we talk about is ovarian drilling. In the process, usually it is combined with a diagnostic hysterolaparoscopy. When with repeated medications, the oocytes, the ovary size is not reducing, the follicles are not reducing, then we will have to go into a surgical intervention. In a surgical intervention, we will be doing a laparoscopic method and drilling out these follicles. And how many we will be doing, how many punctures we'll be doing, it depends on the size of the ovary, the number of follicles available. So yes, this will be a surgical intervention to reduce the size of the ovary by reducing the number of follicles. So that's called ovarian drilling. Now, after a period of time, all this is done and a repeated intervention, repeated ovulation induction and IUI fails, then the last resort would be a IVF process. So yes, it is going to be a long journey, but a combination of patient report and doctors monitoring really helps in managing PCOS. PCOS, when investigated and found in an early phase, is easy to treat and is a treatable thing. So I would like to summarize my treatment. As I already said, for infertility, I have explained why infertility happens. And the first four more things would be definitely, we will ask you to regularize your cycle. And after that, in case it fails, we go into ovulation induction by giving you certain medications and monitor your follicular development. Next would be ovulation induction with IUI. If required, surgical intervention in the form of ovarian drilling will be performed. And following that would be a IVF. So thank you so much. And any questions are more than welcome. And any questions you have regarding PCOS is more than welcome this entire month. Thank you so much.